Welcome back. I'd like to introduce my colleague, Rachel Buckle, who is a specialist gastro dietitian and a trainee advanced clinical practitioner in Sheffield. She recently achieved an MSc in advanced clinical practice, and she's interested in research, particularly in areas of IBS and functional dyspepsia. So I'll hand over to Rachel.
Thanks so much. So today I'm just going to talk a bit about our Sheffield gastroenterology webinars, or webinars in general really. It leads on really nicely from that discussion we were having around the round table earlier, and I think it's something that clearly there's a lot of interest in, and I think over the coming very sort of soon, really, we're going to see a lot more development of this and a lot more use of these services. So why do we need webinars? Well, we know there's an increasing demand in GI dietetic services. So IBS is a really prevalent condition, so it affects around 4% of the global population, and it has a really significant impact on things like people's quality of life. So this affects the individual really significantly and is really demonstrated in the reports by patients about what they're willing to accept to get sort of resolution of symptoms, things like risk of medications or even a reduced quality of life, a reduced life expectancy, which they'd exchange for symptom resolution, showing how much of a significant effect this has on people. It also has effects on healthcare usage and also socioeconomic effects as well. So we know that these symptoms don't generally, in everybody, go away over time, so it's not something that resolves over time. Research varies, but between 17 and 55% of people report symptom resolution or GI symptom resolution over time, which means there's still a significant proportion still struggling with symptoms. We know that these symptoms do change, so patients do fluctuate between the different subtypes of irritable bowel syndrome, so switching between IBS-M, C or D, but these persistent and changing symptoms mean that people are often recurrently using healthcare services, and actually coming back to use healthcare services repeatedly is really common. So we need better symptom management, and we need people to be able to access this. So one of the options we have, as we're all aware, is dietary therapies. So we know that dietary therapies are an effective method of symptom management, and we know from this paper by Tuck and colleagues that in implementing complex dietary therapies, dietitians are really important. They help patients follow these dietary therapies properly. So it improves all three phases of the low FODMAP diet, so they're much better at implementing all three phases with input from the dietitian. And they're also better at implementing the diet itself. They're much more likely to reach that 12-gram threshold, which is considered to be a therapeutic benefit within the low FODMAP diet. So we know that not everyone can access a dietitian. So we know there's very unequal service provision with differing numbers of dietitians depending by region, from some research we did previously into the provision of dietary therapy, the provision of dietetic services across England. Even when they see a dietitian, they're likely to be waiting a long time. For irritable bowel syndrome, the average waiting time is going to be between 2 and 4 months. That's most common. And also, when they do see a dietitian, it's not likely to be for long enough. So the most common length of time that people are seeing a dietitian is between 15 and 30 minutes. And for those patients needing more complex dietary therapies, so like the low FODMAP diet, that's not likely to be an adequate amount of time to deliver the more complex dietary therapies, as well as doing all that assessment stuff that we were talking about in the round table as well. So how are we going to address this sort of inadequacy of care and make sure that people are able to access that dietetic input? We know that we're already using group education sessions in celiac disease and irritable bowel syndrome, and we all know, and I'm sure are very aware, that over the past few years, the use of remote service delivery has been significantly expedited. We've all had to adopt it. This is the case in primary care, where you can see the use of non-face-to-face appointments has really shot up, and that was over, obviously, COVID-19. And then we can also see the increased uptake in the use of video services within dietetic services as well, so video appointments. And actually, within our own research, we saw this. So when we were doing the randomized controlled trial, we had to switch partway through from using face-to-face group education to online group education sessions. And interestingly, there was no significant impact on the effect of dietary therapies when we compared things like online to face-to-face delivery, which is really reassuring when we're thinking about rolling out these services. We also saw that patients did change their diet as a result of the advice. So from the nutritional analysis, we saw that the average FODMAP intake did drop below that threshold of 12 grams, so people were implementing that elimination phase of the low FODMAP diet following this dietary advice. So within the NHS, we're being encouraged to use digital solutions in order to deliver better patient outcomes. So there's these sort of digital playbooks which give us loads of examples about where this is already being used, particularly within gastroenterology. So it can fit into loads of different areas, and when we're talking about things like triage, as we were around the round table, actually that comes into this as well. But I think in terms of patient education materials, the areas of specialist follow-up, so allowing patients to have access to clinical advice, specialist clinical advice in a timely manner, as well as patient self-management, giving patients the tools to empower them to make those changes to help manage their symptoms themselves. These online patient education tools are really important in these areas. So I'm sure we'd agree from what we talked about earlier, it would be ideal if everyone could access a dietitian to talk to them about what dietary changes to make to help with their symptoms. But given the service provision, we need to think about how we generate that access equally for everybody. And I think Emma actually alluded to it previously, this kind of hub and spoke model. So where you've got centres who have more funding, who have more specialist sort of expertise, creating these resources and sharing them and making them available across the country or even wider to allow those areas with less funding to access these resources. It also avoids duplicating work. If you're developing resources, multiple people can use them. It doesn't mean they need to be developed everywhere. This is going to help address some of those inequalities in access to specialist services. We know that some areas, well, 50% of areas don't have access to an IBS specialist clinic, and only 54% have a sort of policy for managing IBS. So hopefully we can use these webinars to help address some of those inequalities and remove that barrier of proximity that exists at the moment to accessing these dietary therapies. Now, these aren't new, so there's been some previous work in Somerset, fantastic pioneering work in webinars where they've been developed and they've been using and evaluating these already with loads of success. So they've been evaluating them, lots of positive feedback, patients commented on the access to reliable information, ability to rewatch the webinars, and the fact they didn't have to travel to access them. Interestingly, and I think importantly, the age of people accessing these was actually really broad. So they had a broad range of ages between 18 and 74 accessing these webinars, and 33% of people accessing them were actually between 55 and 74 years. So although we may perceive age to potentially be a barrier to accessing these services, which it definitely is, it may not, as we move forward with technology, it might be something that people are increasingly familiar with and increasingly likely to use. Patients did advise that the webinars were easy to use, and also they would recommend them to others. And importantly, in terms of service efficiency, they found the reduction in referrals to one-to-one clinics in those first years using the webinar. So it's important not to just design new things out of context. So we need to think about the context of what already exists, what services exist already, and how do we make the services work best for the patients that we're seeing. So I think one of the benefits of the webinars we're looking to develop here is really the website features and functionality, which hopefully over time we'll be able to develop to look at things like triage, think about patients' demographics, think about their symptoms, tracking those symptoms over time. Do these dietary therapies work in this context? And I think it's really important to get that information because we want to make sure that when we're developing new services that these are effective for patients as well. Now this collection of data through a safe and secure way means that patients can interact and personalise their dietary therapies. This is important for our research, as I said, to determine what works for patients, but also allows them to have choice in the matter. What do they want? What do they feel is going to be most effective for them? We're also really lucky to be working with Creative Stream, who are a fantastic team who are going to help our vision for these webinars come to life. Embedded within the website in terms of functionality, we can look at things like assessment of understanding and implementation of dietary therapies. thinking about pre and post questionnaires to assess understanding, but also thinking about dietary adherence as well, and thinking about how we can assess that, although there's a big research gap in terms of how we assess adherence, especially in irritable bowel syndrome and dietary therapies. And really importantly, collecting user feedback. It's so important that patients are involved with the development of these services. They are the expert on their experience, and they are able to tell us what works for them. So if we can continue to collect that data, make sure we've got that information, we can use that to make, consider, and iterate, and think about how we can improve things going forwards. And hopefully, thinking about new tools, are there other ways that we can use things and other things we can upload? Now, there are going to be barriers to accessing online services, to things like online access, digital skills, confidence, and motivation to use these services are all going to prevent some people from accessing them. Now, I think one way we can consider minimizing these barriers is thinking about careful design. How can we make this as easy to access as possible, and how can we make it as engaging as possible for patients to motivate them to use these services? It's also really important that we have awareness of these services, and that's really where we need your help. So just to make sure that once things are up and running and these are available, that we're using them, that we're telling patients about them. They can't use them if they don't know they exist. So it's really important to tell patients and colleagues when these resources exist, so we can use them as widely as possible. It's also important that we give patients trust in the service. We are asking them to give us information, and we need to make sure they understand the safety and security and the consideration that's gone into how we collect and use data in this way. So just coming on to what factors influence uptake of digital healthcare. So what we don't want to do is widen existing health inequalities, and the World Health Organization were concerned regarding the use of digital healthcare and how this was going to impact on the widening of existing health inequalities. So they did a scoping review looking at the existing research as to what encourages people to access, use, and engage, or what prevents them and encourages them to access, use, and engage with digital healthcare. So I don't think the results will be that surprising for people. So those patients that live in urban areas, are white, English-speaking, higher educational attainment, higher socioeconomic status, are all more likely to use or engage or access with digital healthcare. So it's about thinking about those groups, but actually, how we make access as easy as possible, but also considering what the barriers are as well. One of the things that maybe is a little surprising is that people in rural areas tend to not engage with digital healthcare as much as those in urban areas, which, given the lack of travel required, you think may be a benefit. But actually, there are gaps there in terms of access and skills which need to be addressed before they can really reap those benefits of being able to use those remote services. When we continue to develop services and resources, we can look at things like developing resources for people whose first language isn't English. Can we look at translating these webinars, creating webinars that are more accessible? And if we've got these specialist centres who are developing these webinars, they can then be shared. Everyone can use them. We don't need to duplicate that. They can be used everywhere. When we're thinking about other people who may need maybe modifications or accommodations in order to access dietary therapies, it's hoped that as many people are using the webinar, that there'll be more dietetic time to see these people in a way that is more appropriate. So, in conclusion, we hope that in developing these webinars, we have to increase equity of service, we'll be able to use existing services more efficiently, give patients tools for self-management and provide on-demand access, really use, link and share resources, and also consider the feedback, what patients are saying, what other clinicians are saying, and think about opportunities for expansion in this area. So thank you for listening. Any questions?
Thank you, Rachel. That's a wonderful talk. Do we have any questions from anybody?
There you go, Long. Very interesting talk, Rachel. Thank you so much. And my question is, you talked about accessibility, and I just want to know more about what you mean by accessibility here, because working in higher education, we have a lot of neurodivergent students, and I don't know if you have considered sort of neurodiversity when you develop those webinars, or is there someone to sort of oversee the accessibility for neurodivergent patients?
Yeah, I think that's really important. I think the first sort of consideration is, I guess, digital accessibility in terms of making the website as easy to use as possible, as easy to access as possible, with as fewer barriers or steps in accessing those webinars as possible. And initially, we hope that those who are able to access and engage with those webinars are able to do it promptly, and also that then reduces the need for them to see dietitians in practice. So that might then free up the opportunity for dietitians to see sort of other patients who may need more accommodations in terms of implementing dietary therapies. I think it's really important that we do develop resources which do accommodate others, and I think in the future, definitely a major consideration. But I think in the first instance, it's about thinking about how we provide these services for those who are able to engage with them, to free up that time to then give people more of an opportunity to maybe see a dietitian one-to-one who might need it.
Okay, we are out of time, so I'm sure Rachel will be happy to take any questions in the next break.